This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Welcome back to the Endocrine Feedback Loop podcast for our 29th episode. Today, we look at a large observational study from the JCE&M coming out of the German Cushing registry, with the authors attempting to use their data to help us understand for whom Cushing screening is warranted. They use the 2008 guidelines from the Endocrine Society to organize their results. So we will want to review those guidelines as well as carefully consider how these database studies function in order to evaluate whether our clinical practice needs to change. By way of reminder, I host this podcast and work at the Vanderbilt University Medical Center in Nashville, Tennessee, where I am a general endocrinologist, the medical director for our outpatient endocrinology clinics, and an associate director for our fellowship program. Back yet again as our regular contributor is Salila Kira. She comes to us today from Columbia University in New York City. She co-directs the Adrenal Center there and teaches extensively in the medical school and training programs at Columbia. With us for this episode as our guest expert is John Newell Price from the University of Sheffield in the UK. He is one of the world's experts in glucocorticoids and is known to you all for his research in that field as an author of several Cushing guidelines, as the former senior editor of clinical endocrinology, and for many other reasons. So, for a paper on Cushing syndrome, I couldn't have asked for a better pair of endocrinologists. Everything we discuss today will be our opinions only and not of our respective institutions or the Endocrine Society. For this episode of Endocrine Feedback Loop, we review whom should we screen for Cushing syndrome, the Endocrine Society Practice Guideline Recommendations 2008 revisited. Leah Braun from the Ludwig Maximilian University of Munich served as the first author for this paper, which the Journal of Clinical Endocrinology and Metabolism published in September 2022. At this point, I'll turn things over to Salila. She will highlight some of the key points made by the authors in their introduction. She will also get John to give us some insight into the challenges around identifying Cushing syndrome and how the Endocrine Society guidelines were put together. Salila?
Thank you for having me back again. I'm excited to discuss this article. So just to give a brief introduction, Cushing syndrome is a rare condition that's often diagnosed late in the course of the disease. Diagnosis is difficult, and Cushing's is typically characterized and identified by the presence of multiple symptoms. And I think this is a good time just to step back and discuss with our adrenal expert, John, to give us really an overview of why Cushing's is so difficult to identify and his experiences with this.
So thank you, Sarita, and thank you, Chase, for the invitation to be part of this. So the problem we have is that cortisol dynamics and physiology is part of normal health. And so we're left with the situation whereby you need sufficient cortisol, but you don't want too much. And you're trying to discriminate between times when there may be increased cortisol for normal, correct physiological purposes, and excess, inappropriate, and long-term cortisol in the context of Cushing syndrome. And the reason why it's so difficult is because the onset can be, in some patients, fairly insidious or fairly mild disease. It can, of course, be very abrupt, and in that case, often the diagnosis is much easier to make. The real problem we have is that you need a high index clinical suspicion to actually work out which people who may be attending clinics, either in endocrine clinics or other clinics, who should actually then be screened for Cushing's. And what we have to discriminate is between those patients who have autonomous cortisol excess from Cushing's from those who have got what we can call non-neoplastic hypercortisolism, i.e. the patients who have depression, alcohol dependence, glucocorticoid resistance, severe obesity, severe metabolic syndrome, etc., all of whom may have some increases in cortisol. But it's distinguishing them from the patients with true Cushing's that can be very difficult. And so really when one has these mild cases, that can be hard. I think when it's really very florid, it's much, much easier. And of course, when it's florid, it's a medical emergency. So it's those problems of trying to choose the right patients. And then when one gets into, well, once you've decided you may do some screening, then actually one of the bigger risks is in the false positives. So you do some tests and actually you can start going down a route where you may think they got Cushing's, but actually they haven't. They've got one of these non-neoplastic hypercortisolism. And it's important to make sure that you're using your clinical judgment to begin with, because that truly influences how you interpret the tests.
I think that's a great point because, as they note in this study, many symptoms of Cushing's, like hypertension, diabetes, weight gain, or osteoporosis, are very common among the general population, and patients often present with multiple symptoms. Although there's symptoms like purple striae that are quite specific to Cushing's syndrome, the low incidence of Cushing's and the numerous conditions associated with physiologic hypercortisolism can delay a definitive diagnosis and treatment, resulting in increased morbidity and mortality among patients. And studies show that the prevalence of Cushing's syndrome is low. Some studies say almost 0%, others say 3% in patients with diabetes. A recent meta-analysis has shown that the likelihood is higher in patients with advanced type 2 diabetes. Similarly, the presence is low in patients with hypertension. However, screening is recommended in young patients with resistant hypertension or concomitant diabetes. The screening approaches in patients with obesity are actually much more a matter of debate than in the two populations we just discussed, as results regarding the efficacy of such screening differs greatly between studies. And in general, screening of patients with obesity for Cushing syndrome is not recommended. And other populations that may have an increased risk for Cushing's include patients with hypogonadotropic hypogonadism, young patients with osteoporosis and vertebral rib fractures, and patients with central obesity and clinical signs of Cushing syndrome, and patients with an adrenal incidentalloma. So based on the guideline of the U.S. Endocrine Society in 2008, adult patients with unusual symptoms for their age, with multiple and progressive symptoms, particularly those that are more predictive of Cushing syndrome, and with an adrenal incidentalloma compatible with an adenoma, should be screened. And the same applies to children with below average height and above average weight. So I think this is another time to have our expert give an overview of the guidelines and including any unanswered questions that the writers may have had at the time of the development of those guidelines.
But of course, those guidelines were some years ago now. And of course, it's going to be interesting as we go forward with this to discuss how the guidelines fit with the data that's been discussed in this paper. I mean, the three things which we really tried to develop as part of the guidelines were, firstly, who should you test? Secondly, how would you test? And then what those special populations are. And you've alluded to those so far. And in terms of who should be tested, I mean, the reason why we focused on the progressive features, on those with multiple features, was to try and enrich the population for whom it was more likely to have Cushing's, and to try and avoid testing in populations where there was going to be a very low likelihood of Cushing's and where the risk of the false positive then comes to light. And some of these features like myopathy, thin skin, and bruising, of course, they are signs of protein wasting. And protein wasting is a very predominant action of hypercortisolism. So that's a good way to actually conceptualize it. But of course, some patients may present with very mild early stages where such features aren't necessarily present. So who should be tested? Well, we deal with that in the guidelines. How do we test? Well, we use the three main tests of the 1 milligram overnight dexamethasone suppression test, the late night salivary cortisol, and urinary free cortisol. Actually, if you look at the meta-analysis published in 2008 that accompanied the guidelines, so that's by Mohammed Alaman and colleagues, if you look very carefully, in fact, it's the 1 milligram dexamethasone suppression test which performs probably the best. And actually, subsequent data have confirmed that. And actually, of all the tests we use, urinary free cortisol probably performs slightly less well. And so when the guidelines were written, we recommended any of those three tests. And subsequent guidelines have continued to recommend those three tests. But actually, if we're being very analytical, I would say that actually the 1 milligram test certainly performs better than the urinary free cortisol test. And then you've alluded to the special populations, which we tried to think in a different box: the patients with pregnancy, the patients with renal failure, the patients with adrenal incidentalloma. So those are our main three questions, and those are the questions which the systematic review and meta-analysis, which appears alongside the guidelines. I would really encourage people to go back to the 2008 systematic review and meta-analysis that appeared alongside the guidelines and actually look at that as well to gain some more insights on that.
And the authors of this study felt that while a few studies proved the value of screening in certain populations, as we just discussed, that a contemporary reassessment was necessary to prove that the phenotypic presentation has not shifted because of the secular trends in obesity, diabetes, and hypertension epidemiology. So this study analyzed the clinical signs and symptoms that initiate a transfer to a German tertiary center for screening of Cushing syndrome in recent years to test whether current screening recommendations are still valid.
Thanks, Salila, and you did a nice job of walking through all the author's points there, and then John helping us understand how that fits in with many of the questions that we have about identifying Cushing and how the guidelines worked and putting those together. Okay, so we're going to think about the methodology here. As always, we're going to go very slowly and carefully through how the authors put together this study, and that will help us understand the strengths of this study and also some of the weaknesses that'll go along with it. And first, as we also normally do, we're going to think about the study design in general. So I think the best way to evaluate this study to see how the authors put it together would be looking at it as a cross-sectional study. And the idea of how a cross-sectional study works, it's built into the name, is that it's a cross-section of a population. And I think a couple of things are important to keep in mind, in particular for this study as we move forward. And one is that this is not a cohort study. So cohort study, what sets cohort studies out amongst the observational literature is that cohort studies follow people over time. So you will split people into groups based on whether they have an exposure or do not have an exposure, whether they're unexposed. And then there's a time component to where you're waiting for outcome or outcomes of interest to develop. Cross-sectional studies are different. They don't have that time component. You're getting all of that information roughly at a single point in time. Sometimes that can be a little bit hard to think about when that one point in time actually takes a little while to get some of this information. So we'll see this in this study is it actually takes several weeks, probably several months for all of this data to be collected. But I still think it's most accurate to think of it as a single point in time while all of that data is being collected, because individuals are not followed over time for the development of an outcome. So that's a cross-sectional study there. And the other thing that we'll have to think about, again, just with any observational studies, that people are split into groups based on an exposure that they have or not having an exposure at all. So another thing for us to think about here. So we'll come back to this and think about this further as we get into this study. So first of all, we're going to look at the patient population. That's going to be an important thing for us to consider, because often these cross-sectional studies are not of a general population, but they're of a much more specific population. And that's going to affect how we interpret this results, whether it's a specific subset of folks or a population at large. So this one is a specific group of individuals. And this patient population comes to us from the German Cushing registry. And John, I was hoping we could pause here and maybe have you give us a little bit of insight. I think most of us are probably not terribly familiar with this registry. So give us maybe just a really high-level overview of what this registry is and how it works.
I think this registry is an example of what can be done if things are set up well and properly. So I think great kudos has got to be given to Martin Ranke, Felix Buschlein, and others who set up the registry back in 2012 to map systematically what happened to patients in terms of the diagnosis, treatment, and outcomes in patients with Cushing's, using a standardized way of looking at it amongst some different centers. And the data in this paper are from the Munich Center. And just by way of insight, they've achieved an incredible thing that over 10 years, they've published about 86 papers from this registry, of which 26 are first author papers by young investigators. And they have given new insight into how Cushing's is not only diagnosed, but about the management decisions that we all face. I think it's been a very, very big success from a prospective registry, but done so that people are using a similar approach across some different centers. So I think that's really the strength of how these data have been gathered and the strength of the German registries, because there have been plenty of other registries that have been set up that haven't been anything like as successful as the outcome. And there are more papers coming out which are answering some of the difficult questions that we face in this field.
So that's the registry that we're talking about. And just like John mentioned, this is specifically looking at individuals who are seen at the Munich Center, which is a tertiary center for Cushing syndrome. Since 2012, over those about 10 years, there were 432 patients who were seen for that. And those are the group that we're looking at here. An important thing to think about when we think about individuals referred to centers like this is that you have to be worried about a referral bias. This isn't anything that the authors did incorrectly, but this is an intrinsic limitation of whenever you're having studies come out of large centers like this, is it may not be broadly applicable to the rest of the population, because often, not always, but often a unique subset of patients will be referred to these centers. And sometimes you have to think about it. These may be the more complicated, rare, unusual cases. And so there may be limitations in how we can apply that to the population at large. So something to keep in mind here. So of those 432 patients, they were able to include 377 in this study. They had to exclude a few individuals, so some who had already undergone some degree of biochemical testing, and reasons that will become clear as we look at the rest of the methodology here. Also, they eliminate anybody who was determined to have a genetic form of Cushing syndrome, and also those few individuals who had incomplete data. But still, a large number for a rare disease, a large number, 377 that we're looking at here. And John alluded to the testing that was done here. It's a very standardized set of testing to evaluate for cortisol excess, a 24-hour urine-free cortisol, a late-night salivary cortisol, and a 1 milligram dexamethasone suppression test. The authors make a comment that they did all three of these tests, but only one of each of them. However, they had the option of repeating the urine-free cortisol or the late-night salivary cortisol if they were concerned about a false positive or a false negative. And the example that they gave, I think, is one that would make sense to everybody, is that if they were worried about an inadequate collection, so I would infer from that as a possible further example is if the creatinine on the 24-hour urine-free cortisol was too high or too low, then they might be worried that was not a good collection. And so they had the liberty to repeat one of those tests. I would say, just as an aside here, and this is another thing that we'll have to think about, is this at least introduces the possibility of an ascertainment bias. And what an ascertainment bias is if the authors are looking for something different in different subjects. And again, I think the example that's provided would be a very logical one to do. But when there's liberty to say, well, for this person, I'm going to look for an outcome this way, but for this person, I'm going to look at it in a different way, there's at least the possibility that you're going to find things because you are looking for them differently depending upon the individual. And so I think that's something that we're going to have to keep in mind here. So that's how the testing was done. Now we're going to think about the outcomes that are used here, the way that they're described. So the final diagnosis is a combination of quite a few things. And the way that the investigators describe this, they say a final diagnosis was based on signs and symptoms, the biochemical testing, the surgery outcome, the histopathology, and follow-up. So again, I think this introduces the possibility of an ascertainment bias. And a lot of this is going to have nothing to do with the investigators having done something right or wrong. So for example, not everybody underwent surgery. If you had biochemical testing that suggested you did not have Cushing, you should not undergo a surgery. And so because of that, there's going to be different information, different outcome data that will be available for some patients versus another. So at least we're going to have to keep this in mind, is that not everybody was evaluated exactly the same, and so may affect some of the outcomes that we're thinking about. But with that, the results is that 93 individuals were determined to have Cushing syndrome with this evaluation. 284 were determined to not have Cushing syndrome. And then for those who were determined by that initial testing, that biochemical testing, to have Cushing, there was a further evaluation to try to figure out the subtype. And that included, first of all, a CRH test, and then if needed, an IPSS and imaging. And then, as mentioned before, if you had a surgery, the final outcome was based on the results of that surgery. So, John, let's stop here again and have you help us out thinking about, in particular, this subtyping. So as you look at this, as you look at the way that the authors describe what they did, how does that compare to other options that exist for how to both diagnose Cushing and then subtype Cushing syndrome? And any comments that you might have about that evaluation?
So I think it compares very well. I mean, these are world experts who are involved in this study. And so, unsurprisingly, they've done the right tests and will have typically done the right tests in the right order. So first and foremost, one essential point to make is that no attempt at subtyping Cushing should be made until you're absolutely sure that someone's got Cushing's in the first place. So if there's doubt, far better to reassess at an interval than starting going down the differential diagnosis. And a trite sort of example here is that we all have a gradient from our pituitary to the periphery of ACTH. So we will all have a positive petrosa sinus sampling study if one was done, but we don't all have Cushing's. So that's why it's so important to make sure that someone's established first, so they have Cushing's, and then secondly, to go on to the subtyping. In terms of the subtyping approach, it varies amongst different centres. There will be centres who feel that virtually every patient with ACTH-dependent disease should have an inferior petrosa sinus sampling study. There are others And I think that when you read through the data here and the way the authors presented, if there is a clear tumor on MRI scan, a clear response on a CRH test, then I think they will be more in the camp of not going down the route of inferior pterosis sinus sampling studies in every patient. And that is reasonable. But this varies, and it varies between access to investigations, and it varies in terms of the experience of the investigators. And I think we should remember that if you've got ACTH-dependent Cushing's and you're a woman, before you do any test at all, you've got a 90% chance of that being Cushing's disease. So any test you do has got to improve on that 90% chance. It's different in men, so it's around about 60% in men will have Cushing's disease and the rest will have ectopic in ACTH-dependent disease. So the way you interpret these tests are also inherently influenced by the pretest probability. Some physicians will feel that if you've got a clear adenoma, particularly if it's a macroadenoma, and you've got a positive CRH test, you've got Cushing's disease, that's okay. The more recent consensus guidelines suggested, which was published by Maria Fleischer and many other authors at the end of last year, if you've got a tumor between 6 to 10 milliliters or 6 to 9 millimeters, and you've got a CRH test that's positive, and you've got a negative CT scan of your body, excluding ectopic, that may be sufficient then to say, well, I don't need an inferior pterosis sinus sampling. You actually then just allow the pterosis sinus sampling study for any areas of doubt. Or there are other centers that say, well, I don't mind. If I've got ACTH-dependent disease, I want an inferior pterosis sinus sampling study if there's a 2 or 3 millimeter area within the pituitary. So it is variable. There isn't a right or wrong approach. It's just very important that whoever is doing this approach is doing it regularly, has got the right team members around them, and actually can interpret the data carefully to then advise the patient appropriately.
Thank you, John. Again, very helpful to think about that. And so that we just walked through is really the outcome information. So when we're thinking about who has Cushing, who doesn't, when we think about it in terms of that cross-sectional study, this is what we're trying to figure out. So this is the outcome. And just like John mentioned, this is really one of the great centers in the world for identifying and treating Cushing. So this is really going to be the best of the best that we have as far as determining that, a process that is fraught with difficulty and often done incorrectly. But this is going to be probably the best example that we can come up with here. So now what we want to do is we think about this, we'll say, well, what's the exposure? If that's the outcome that we're interested in, if we're going to have different groups and we want to see if one group has an outcome more than another group, well, how are we splitting those groups up? So that's the exposure. And the way that this study is built is it's the chief complaint. And the authors group these together. So they looked through the referral information that came to their center, and then they used the 2008 guidelines to put individuals into different categories based on how those guidelines describe reasons for testing for Cushing syndrome. So the way they described it, and I'll give some very high-level groupings just as the authors do, and then as Salila walks us through these results, they'll make a little bit more sense, but they put them into one of 4 different categories. So one is an unusual feature for age, an example that the authors gave. So you had osteoporosis at a young age. That would be a good example of that. So that's one exposure. A chief complaint is some unusual feature for age. Another one is having multiple and progressive features, and multiple meaning greater than 3 of that long list of signs and symptoms that can go along with Cushing syndrome, having more than 3 of those and progressive. And then a third one is having that adrenal incidentaloma that's consistent with an adenoma on imaging. So those would be the 3 that we would say that the guidelines in the form of 2008 would support testing for. And then they had a final category say, well, we got somebody who was referred to us but didn't meet any of these, couldn't put them in any of these categories, and so there would be a none of the above, essentially. So that is the exposure, one of those 4 categories, 3 accepted reasons for testing, and then a 4th that could think of that as being unexposed or just another type of exposure, but everybody ended up in one of those, and then we're going to look and see, is it more likely to have Cushing, yes or no, depending upon which of those groups that you're in. So that's how we want to think about this cross-sectional study. So Leela, we're going to turn it back over to you at this point and have you walk us through all these results so we can think really carefully about how this plays out.
So moving on to the patient characteristics, unsurprisingly, 76% of patients in both groups were female, and patients with Cushing syndrome were older than those ruled out for Cushing. So the average age in the Cushing's group was 49 years, and in the group that did not have Cushing syndrome was 36. Blood pressure and hemoglobin A1C were significantly higher in patients with Cushing syndrome, and both groups had similar BMIs. And of the group with Cushing syndrome, 67% were diagnosed with pituitary Cushing's, as we were just speaking about, 28% with adrenal Cushing syndrome, and 5% with ectopic. And John, I'm curious to know, is this comparable to the breakdown that we see with the US and the UK data as well?
So I think it's very similar is the short answer. The slightly longer answer is that traditionally one's thought about the breakdown of approximately 20% being ACTH independent and approximately 80% being ACTH dependent. So it's a little bit of variance from that. And I think looking through these data, that is probably going to be accounted for by the adrenal incidentalomas nudging up the number of the ACTH independent. But broadly speaking, it's pretty close. And so to Chase's point about ascertainment bias, it's actually not so far from many other major series. And so I think we could be reasonably reassured that what we're seeing here is fairly representative of the types of patients that we'll be presenting for the assessment of Cushing's.
And they identified 18 different chief complaints for which patients were transferred to this tertiary center. The three most common reasons were obesity or weight gain, and about 25% or 24% of the patients presented with that chief complaint, an adrenal or pituitary incidentaloma, and about 40 patients or 11% of the patients who presented to this registry had that chief complaint. And then hypertension actually had the similar number of patients, 40 patients, and which is 11% of those presenting to the center. Half the patients screened for Cushing syndrome belong to the groups that are not counted as priority groups as recommended by the 2008 guidelines. So Cushing's was diagnosed in 12% of those patients compared to 39% among those who fell into the screening groups that Chase delineated. So they're in the study are delineated as groups A to C as recommended by the 2008 guidelines. Group A, as we previously noted, consisted of patients who had unusual features for their age. As Chase discussed, a young patient with osteoporosis or a young patient with hypertension. And in this group, 12 out of 52 or 23% of the patients were diagnosed with Cushing syndrome. Group B had patients with multiple, as defined by greater than 3 symptoms and progressive features, particularly those that were predictive of Cushing syndrome. So 18 patients presented with more than 3 typical symptoms of Cushing's, and of that group, 15 of them were diagnosed, or 83% were noted to have Cushing syndrome. And myopathy was the chief complaint in 14 of those patients. And as John was saying, given the protein catabolism that's associated with Cushing syndrome, this is not shocking. And Cushing syndrome was confirmed in 64% of these patients. Metabolic syndrome was also common, 22 patients, with 45% having Cushing syndrome. And 28 women presented with hyperandrogenic symptoms, and 21% of them had confirmed Cushing syndrome. And group C patients are those that had an adrenal or pituitary incidentaloma compatible with an adenoma. And there were 40 patients in this group, of whom 40% or 16 patients received a final diagnosis of Cushing syndrome. So group D consisted of 203 patients that essentially didn't fall into any of these other categories. So they did not fit into either categories A, B, or C. And of those, only 27% received a final diagnosis of Cushing syndrome. So only 25 of these 203 patients had a final diagnosis of Cushing syndrome. Of the chief complaints, 5 were significantly more frequent in Cushing syndrome. And those were osteoporosis, incidentaloma, metabolic syndrome, myopathy, and multiple symptoms. And multiple symptoms were the most important aspect, increasing the probability for Cushing syndrome, and the odds ratio was 18. Obesity or weight gain were more common in those in whom Cushing's was ruled out, decreasing the probability for Cushing's, and the odds ratio of 0.11. And obesity and weight gain were the most frequent chief complaint to screen for Cushing syndrome, with 89 patients presenting with this complaint. But only 4% of these patients had Cushing syndrome, 3 of whom had acute weight gain within the past year. And obesity was a presenting problem that made the diagnosis of Cushing syndrome the most unlikely.
So a bunch of information to go. So we're going to go back through that a lot. And as we normally do, we're going to use the way the authors walk through their discussion as our framework. And then as we go through the points that they make, we'll make a few points of our own along the way. So first of all, we're going to start with how the authors describe their findings, their main findings. And I'll add a caveat to this because I think we have to keep thinking about this is this is among a group of individuals that there was enough of an index of suspicion for them to be referred to a Cushing's center. So this is not a general population that this is a cross-section of, but this is a group that some provider somewhere have an increased index of suspicion for. But among that group, the guidelines, when applied appropriately, identified 73% of the cases based on this either having unusual features for age or multiple and progressive features or incidental illness. However, chief complaints were present for those other 27% of patients who ended up having Cushing's syndrome. So a few comments beyond that the authors make. So they point out that in their center, that half of the patients that they saw did not belong to a group for whom screening is recommended. A couple other points that they make is that, interestingly, at least in what was commented on in the information that they had, psychiatric disease is a very uncommon reason for referral. They note this because they say that in individuals with cortisol excess, it's very common to have psychiatric disease. And so it was interesting that was not something that was at least mentioned in the information that they had. They point out that on the flip side of that, PCOS-like symptoms were actually a fairly common reason for referral. And then another point that they make, and this is something that we'll want to spend a little bit more time thinking about, is obesity. Salila just walked us through some of that information. So the authors point out in summary that obesity was the most common referral reason, but it rarely turned out to be from Cushing's syndrome. And the authors conclude that their data support the recommendation to not screen patients with long-lasting obesity as a singular complaint, or at least as the main complaint. So I thought this would be a helpful one because I think that we likely see a lot of this as an increasingly common condition is obesity. And so one that we're having to think about this more and more and more is, could there be an underlying identifiable hormonal defect like excess cortisol production? So I want us to think about this a little bit. So Salila, you walked us through those results. Any thoughts that you would have? You work in an adrenal center, you co-direct it, so you see a lot of folks that have this question of, am I making too much cortisol? So how do you think about this result? How does that fit with your practice, and how would you evaluate that?
I think these results are consistent with what I see in my practice. The interesting thing that they note is that it's weight gain, and especially over the last year, that maybe, and it's hard to parse out from this data, but that may be more helpful in thinking about which patients have Cushing's as opposed to patients who have had excess weight or obesity for most of their life, that it's probably less helpful. I think that weight gain in association with some of these other symptoms that may be more consistent with Cushing's is helpful in sorting out whom to screen. But I tend to agree with their conclusion that just weight gain or obesity over a long period of time is not really the best indicator to suspect Cushing's. And I'm interested to hear if that's consistent with what you experienced, John, as well.
Oh, absolutely. I mean, I think, again, it's down to careful history taking. I see or get referred quite a lot of people who wonder whether they've got Cushing's, who have been obese for decades. And of course, in those people, it's highly unlikely they have Cushing's. Alternative, the people who are experiencing it over the shorter period of time, well, I think I'm much more persuaded there could be an issue there, particularly if you then got, even though that might be the index thing, then you got to tease out perhaps some of those other problems. So it's interesting about what you were just saying, Chase, the issues that some people may have with their mental health or psychiatric health, because quite often that's just not thought about carefully enough or asked about carefully enough, particularly things like cognitive difficulty and also difficulty sleeping. So if you've got someone presenting with obesity, particularly the more recent onset, then there may be some other things which need asking about, which may then trigger. But absolutely, I would really advise against screening purely on the basis of long-standing obesity where there's no other feature.
Yeah, I found that a particularly helpful distinction that the authors made is how long the obesity has gone on for. That if this is a really new thing, meaning within the past year, that's a different scenario than just like John said, somebody's had this for years or maybe even decades. And I think John's point's also a good one, is that we probably do too much testing in that patient population, but potentially in those with psychiatric disease, it's at least possible that we don't do enough, or at least it was what the authors pointed out, that that's not a very common reason to get evaluated in their center for excess cortisol production. Good. So another issue that the authors raise, and one with maybe a little less clarity on what we should be doing, is how they describe it something as an economic perspective. And so that's thinking about how much screening should we be doing. And they present arguments and have some nice references for different approaches. And they point out that some experts argue for expansive screening, that we should be testing more individuals to see if they have Cushing syndrome. And the argument behind that is the impact of a delayed diagnosis of Cushing syndrome. There have been plenty of papers published that have shown that for the average patient, it takes months, if not years, for somebody to figure out that they have Cushing syndrome, and that can have a devastating impact on that individual. And then on the flip side, they point out several arguments that are made by other experts who argue against expansive screening, with the understanding of testing more and more people who are less and less likely to have Cushing syndrome is going to make it less and less likely that we'll find anybody, and usually at a fairly high expense of doing that. So I think this would also be another helpful thing. The authors don't try to resolve this issue, merely pointing out that there are differing approaches that are out there. So John, maybe we'll get your input on this as somebody who helped write guidelines. Obviously, you helped write the 2008. We're evaluating those here. But what were your thoughts of when you layer in that economic perspective and trying to think, should we be doing more of this or less of this?
Of course, I would not want to miss the diagnosis of Cushing's. I think all of us have been humbled by trying to make a diagnosis and have missed it, and or have thought they've made it and they've been wrong. So we've all been humbled by trying to make the diagnosis. However, I'm strongly in the camp of not for widespread screening. I think the screening needs to be targeted to those people along the lines that we wrote in the guidelines. I'm reasonably reassured that what we wrote in 2008 appears to be pretty useful and still applies in 2022 to a greater or lesser extent, or to a greater extent. And so I understand the notion that you don't want to have people with more advanced disease to their health detriment, and in fact to a greater health cost. But I'm concerned that less or more indiscriminate, widespread screening carries, I feel, a great risk of actually not finding very many patients, costing a lot of money, and potentially causing an awful lot of psychological harm to those people who then get wed to the notion that they've got an underlying diagnosis when it just isn't there. And that could be avoided by not doing the biochemical screening in the first place. And I think the notion of, if one is unsure, of repeating a clinical evaluation at an interval, if there haven't been progressive features, it just makes it much less likely. So from an economic perspective, I understand both arguments, but I'm certainly in the camp of against expansive screening.
And as we wrap up here, we're going to look at some of the limitations and strengths, and we're going to start with the ones that the authors point out themselves. So a couple limitations that they do point out: that referral patterns are likely to be affected by reimbursement policies, and those obviously vary widely from country to country and healthcare system to healthcare system. So they say that the results from their center may not be broadly applicable, since we may see very different referral patterns in other places. They also point out that they were not able to comment on racial disparities in their evaluation. They do point out as a strength, though, that they had a large number of patients and they had a prospective design which allowed them to very carefully think through what information they would want to have and include that, make sure that was obtained in this evaluation. And so I wanted to stop here and think about any other potential either strengths or limitations. Salila, we can start with you. Anything else that you would add that we have not touched on already and that the authors didn't mention here?
No, I think they did a very good job of delineating both their limitations and their strengths. You know, as you spoke about when you were discussing the type of study that this is, that there are some inherent biases associated with any kind of referral center or a tertiary center. But I think that, you know, regardless of that, the study, I think, had a lot of strengths and really gives us a lot of information to really assess whether the guidelines are still applicable. And I think the conclusion that they are is based on good data that they presented.
Good. Yeah, we'll come to that here in just a second as we think about how to wrap this up and evaluate it as a whole. But John, any other strengths or limitations that you would want to comment on before we do that?
No, I mean, I think you've both covered it. I think they have been very careful in assessing both their strengths and limitations. Inevitably, being a tertiary referral centre, one may argue that the population they're seeing is not broadly applicable to perhaps the population seen elsewhere. However, the strength is that the patients have all been assessed in a very consistent fashion. So I think it works both ways. And in fact, it's interesting that it is still consistent 12 years on with recommendations that were previously made. Those recommendations based both on data and on expertise. So I think really the overall balance that they've struck, I think, is a good one.
Good. That's a perfect segue into the conclusion. So as the authors describe their work, they say that there are really 5 reasons for screening for Cushing syndrome that increase the likelihood of having Cushing. And they list those as myopathy, metabolic syndrome, osteoporosis, adenoma, and multiple Cushing specific symptoms. They also point out, as we've discussed, that obesity alone in this population decreases the probability of having Cushing syndrome. And that finally, just as John suggested, that patients falling into one of the 3 categories that were suggested by those 2008 guidelines do warrant screening. So now let's take a step back and put this into a whole here. So we've really talked about the quality of this report already. We've mentioned that with some intrinsic limitations because of this being a tertiary care center and a place where folks are referred to, that there's going to be some limitations. The authors pointed that out as well. But I think overall have been very impressed with the quality of this report. As John has pointed out, we've come to expect from this group for many, many years and many, many excellent reports. So what I wanted to end with now is thinking about how this might change our clinical practice as a whole. So Leela, let's start with you. As you see folks frequently referred to you, one of the many questions that you get asked is, could this patient in front of you have Cushing syndrome? How will this information change your practice? Will it make you do anything differently? Will it simply confirm what you're doing? How would you think about that?
I think it gives us more confidence that what we're doing in following the 2008 guidelines is data driven and based on, more recent data that confirms that those are the right approaches. I think in particular, really paying attention clinically to young patients with osteoporosis or fractures, especially vertebral fractures. I think that's an often overlooked sign of Cushing's. The authors here discuss about the importance of looking for clinical symptoms such as fractures and really paying attention when a patient has multiple symptoms. And also maybe stepping back, I think if anything, this may lead to a change in less screening in the sense that patients who've had a lifelong history of obesity perhaps don't need to be screened for Cushing's, and really using this like how the rapidity of weight gain as a symptom as opposed to just weight gain in general or obesity in general. So I think if anything, this affirms what many of us have been doing at referral centers and and in practice since those guidelines have been published 14 years ago. So
yeah, I agree. I found their comments on how to think about patients with weight gain and how to apply these results to that. I found that particularly helpful. But John, you're our guest expert today. Let's wrap things up with you. What are your thoughts about changing our practice? Is this going to shift what we do, or does it confirm what we're doing right now? How would you put that together for us?
Well, so I completely agree with what Celia's just said. For me, I think one of the more useful aspects is not only affirming that the approach for making a positive diagnosis appears to be reasonable. The 2008 guidelines still hold utility, but really the affirmation that screening widely in patients who had long-standing obesity is really not something which we should be doing. And I think this is good data to support that. So I think when people are considering that and are referred patients or seeing patients where that is the primary and only issue and the obesity has been present for a long, long time, then I think that not doing tests is really the most important take-home message from this paper.
And with that, I would like to thank Salila Cura and John Newell-Price for joining me for this month's edition of Endocrine Feedback Loop. I learned a great deal and know that you all did as well. Please join us again next month. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you as a members-only benefit of the Endocrine Society, with production oversight by Andrea Quillas Sanchez.